Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hi everyone, I'm Paolo Tarantino, a breast medical oncologist and advanced fellow at the Dana-Farber Cancer Institute in Boston, USA, and I would like to welcome you all to this program titled Hot Topics from Berlin 2025, what experts say about the future of metastatic breast cancer care. And I'm extremely fortunate to be joined to one of the greatest experts in the world in the field, Dr. Valentina Guarneri, that is professor of medical oncology at the University of Padua in Italy, and Dr. Rebecca Dent, that is professor at the National Cancer Center in Singapore. Valentina, Rebecca, welcome.
Thank you.
So we will review some of the greatest, most important novelties that were presented at this conference. There's many, so bear with us. And we're gonna try to divide them in chapters. We're gonna start from ER-positive disease, and I would like to start by reviewing some of the practice-changing trials and hearing what you thought about these trials, these studies, especially because the field is becoming quite crowded and we really need some expert opinions. So let's see what was presented. We saw the presentation, the first presentation of the data from the evERA phase 3 trial. This was a study conducted in the second-line ER-positive, HER2-negative metastatic breast cancer setting in a quite clean population of patients that received 2 or less prior line of endocrine treatment, that had prior progression on CDK4/6 inhibitors, no prior chemotherapy. So it was kind of a clean second-line setting where patients were randomized, 373 patients randomized to giredestrant plus everolimus or standard of care endocrine treatment plus everolimus, which could include typical endocrine treatments such as aromatase inhibitors or fulvestrant or tamoxifen. And the primary endpoint was progression-free survival in patients with ESR1 mutations. Co-primary was PFS in the ITT population. And what we saw in the study was that in the ESR1 positive population with mutations in ESR1, there was a major improvement in PFS, almost doubling from 5.45 months with the start of care endocrine treatment everolimus to almost 10 months, 9.99 months with the combo of giredestrant everolimus, and for an hazard ratio of 0.38, which was statistically significant. And similarly significant results were observed in the overall population, including patients with ESR1 mutations and without ESR1 mutations, with a slightly shorter delta in PFS with a hazard ratio of 0.56. There was an exploratory analysis among patients that didn't have ESR1 mutations, which showed that there wasn't a meaningful advantage in PFS, but this was exploratory. And of course, this needs to be put together with the fact that actually there was an improvement in response rate across the board in patients with or without ESR1 mutations, and there was a positive trend in overall survival across the population, which is still immature, of course. Whereas in terms of safety, most of the signals, the toxicities, seem to be related to everolimus. So stomatitis was the most common toxicity, about half of the population, mostly low grade, and then diarrhea, anemia, nausea were also seen, but overall it seemed to be a manageable regimen. I will see what our experts feel about this. Let's move to the second trial, phase 3 trial that was presented for the first time at this conference. Similar to evERA, we already knew that this other trial, Victoria 1, was positive. It was a press release, but finally we saw the full data presentation. Similar population, a population of patients with ER-positive, HER2-negative metastatic breast cancer who had progression on first-line endocrine treatment and CDK4/6 inhibitors, less than 2 lines of endocrine treatment, measurable disease, which may be important to understand the outcomes of the population, no prior mTOR inhibitors, PIK3CA or AKT, no prior chemo. patients were randomized. This is a study with two phases, with two different cohorts, PIK3CA wild type and PIK3CA mutant. We only saw the results in PIK3CA wild type, and patients in the PIK3CA wild type cohort were randomized to gedatolisib, palbociclib, fulvestrant, gedatolisib, fulvestrant, or fulvestrant alone, where gedatolisib is an inhibitor of both PI3K and mTOR, so a pan inhibitor of the entire pathway. Primary endpoint PFS in each experimental cohort versus fulvestrant. And what we saw is that the triplet cohort improved progression-free survival from 2 months with fulvestrant to 9.3 months with the triplet for an hazard ratio of 0.24, which was statistically significant. And even when you look at the doublet of gedatolisib, fulvestrant versus fulvestrant alone, you see an improvement in PFS from 2 months to 7.4 months, which showed at another ratio of 0.33, which was statistically significant. And in terms of toxicity profile, the main side effects with gedatolisib is stomatitis, observed in about 70% of the population, grade 3 in 20%. Also, palbociclib adverse events were observed in the triplet combination, such as neutropenia. Rash was also seen, although it was not too common, about 30% of the patient getting gedatolisib, and diarrhea and hyperglycemia were quite low in their incidence. So the main side effects observed in the gedatolisib arms were stomatitis. So let's move on just rapidly across two PROs, patient-reported outcomes from two important trials recently presented. SERENA-6, a trial of camizestrant escalation for ESF1 mutation appearance in the ctDNA. We already knew that PROs were favorable. Now we saw them in detail, and we saw that camizestrant, compared to continuing aromatase inhibitor, improved several points of quality of life across the board: emotional functioning, pain, fatigue. All of the endpoints of quality of life seemed to be improved, or at least at an hazard ratio less than 1 with camizestrant, suggesting a benefit. And also VERITAC-2, there is another trial of vepdegestrant versus standard of care endocrine treatment with fulvestrant, showed positive quality of life data with a nice separation of the curves for in general health status, and also for other endpoints of quality of life, such as worse pain, pain severity, and pain interference. So overall, I would say that we are having more and more data suggesting that oral SERDs can be beneficial for our patients alone or in combination. And now the hard question: what was your general feeling regarding this data we saw at ESMO? I will start from Rebecca. What did you feel about this data?
So first of all, that was extremely well presented. That was very complex data, and you really put it into context for me. And I think of the two abstracts that you presented to us, what was really striking to me is that, there are differences in terms of schedule. There's differences in terms of toxicity. I, first of all, think it clearly shows that last abstract that you showed us, the PFS of 2 months for fulvestrant. There's just no role for giving single agent fulvestrant. It's just not single agent endocrine therapy, for that matter, after first line therapy or a combination therapy. Beyond that, I just don't think there's a role for it. So I think that's the first point. The second point is, I think for the most part, combination therapy after progressing on a CDK and endocrine therapy, under the selective pressure of that combination, I think we know that when patients come off that, they need a combination therapy. And then the second sort of abstract, I think the data is really quite compelling, but the every IV week for me, that in a hospital, that's a lot of chair time. I think the time toxicity there is a lot. But I am reassured by the side effects that they were seeing. They were a lot less than what we've observed previously with the similar compounds.
Thank you for these great points, and I couldn't agree more with all of these points. I would like to delve more into the IV portion, because I think this is the first time we see really a combination including an IV agent. Gedatolisib is given weekly IV, 3 weeks on, 1 week off. And do we think, Valentina, that there's a role for some patients for this triplet of an oral drug, an intramuscular drug, and an infusive drug in the second line? Or do you feel that may be a major barrier to the use of this treatment?
Of course, it depends on the patient. So the point is that the data are very interesting to me, and of course, when discussing, I agree with you. Of course, we will have to to calculate the impact of this approach in our clinic, because you know that an IV infusion weekly really has an important impact. Also considering that we for years we are discussed about the fact with oral drug we can have less pressure on the patients, on the needs to come in the hospital. So for a lot of drugs, after the first assessments every month, and now we can really have the delivery of drug at home. We learned with COVID that we can safely manage patient with televisit and so on. So I think that this can be an issue, but in the end, when we recall I usually recall the drop of the cures that we have seen at the trial with single agent camizestrant or single agent elacestrant. So there are patients that rapidly progress when starting second line therapy. So I think we have to work on patient selection to offer the triplets rather than the doublets. But as said, fulvestrant single agent, I think, is no longer something that we have to offer to our patients, irrespective by ESR1 mutation.
Even just looking at the control arm of Evera, seeing start of care endocrine treatment and everolimus having more than 5 months PFS, I think is reassuring. It suggests that even with the old standard, we do see some activity in combination. So overall, seems like having option is always a good thing. It will allow us to tailor treatments, and options are expanding, actually, thanks to ESMO, for all breast cancer subtypes. So let's review a little bit of the data we saw from HER2-positive disease. I will ask Valentina to guide us through the novelties in HER2-positive metastatic breast cancer.
Thank you. Really, I'll be happy to review with you some of the presentation in the HER2-positive metastatic breast cancer subset, starting by the updated of the Destiny Breast 09, in particular the analysis of some subgroup in the DB09 study. So just to remind, the DB09 is a trial dedicated to patients with metastatic HER2-positive breast cancer without prior treatment, so it's a first-line therapy. And so patients were randomized to 3 arms, the Ruxtecan plus placebo, and we do not know yet the data from this arm, to trastuzumab deruxtecan plus pertuzumab, or to the standard THP therapy. And the primary endpoint of the study was PFS, key secondary aim OS, and we have seen exploratory preliminary results from the OS analysis. Patients were stratified according to having de novo versus recurrent metastatic disease. The population of de novo patients represent approximately half of the population. According to hormone receptor status, again, approximately half of the population. And according to the presence of PIK3CA mutation. PIK3CA mutant tumors in this study was detected in approximately 30% of the patients. These are of course, we already seen the results of the primary endpoint, so really significant and clinically meaningful improvement in PFS for the deruxtecan plus pertuzumab versus THP. And at ESMO, we have seen the results according to the stage 4 de novo or recurrent. And as you can see, we observe again a significant improvement in PFS. The median PFS is not reached for the de novo stage 4 disease patients, and is 31.2 months for the patients treated with THP. And as expected, we have a shorter PFS for the patient presenting with recurrent disease, still an important advantage favoring TDXT plus pertuzumab, median PFS 38 months versus 22.5 months observed in patients treated with THP. So the benefit consistent regardless of de novo or recurrent status. The analysis according to hormone receptor status shows similar results, so consistent data in terms of the improvement in median PFS for the deruxtecan plus pertuzumab versus THP. I think that here maybe we will discuss later. The fact is that the population of patients presenting with hormone receptor positive disease did not uniformly receive the hormonal therapy. So hormonal therapy that was allowed in both arms was in the end prescribed in 13% of the patients treated with the deruxtecan plus pertuzumab and in 38% of patients treated with the THP. And again, very, in my view, interesting information regarding the population of patients with PIK3CA mutation. We know that PIK3CA mutation is a prognostic factor, so we can see that the median PFS is shorter in both arms in patients harboring PIK3CA mutation as compared to patients without the mutation, but again, a consistent benefit favoring TDXD plus pertuzumab versus THP, regardless of the presence of the mutation. But again, these data are interesting in my view, considering that there are data also exploring the possibility of introducing PIK3CA inhibitor in the context of HER2-positive disease. I've mentioned the PATINA trial. At ESMO have been presented the results of patient-reported outcomes from this trial. Just a quick summary of the study. In this study, patients with the hormone receptor positive, HER2-positive metastatic breast cancer, after 6 to 8 cycles of induction therapy with trastuzumab, pertuzumab, and taxane treatment, were randomized to continue trastuzumab, pertuzumab, and hormonal therapy plus the addition of palbociclib versus only pertuzumab, trastuzumab, and endocrine therapy. And we have seen really impressive results in terms of the median PFS, which was more than 44 months for when adding palbociclib in the treatment plan of these patients as compared to continue the dual HER2 blockade plus hormonal therapy. In the control arm, the median PFS was 29 months. And so these data are very interesting to be contextualized in the evolving scenario of the first-line treatment of HER2-positive and hormone receptor-positive metastatic breast cancer. And at ESMO, as mentioned, we have seen the results of the patient-reported outcomes that are totally reassuring. The addition of palbociclib in the context of this scenario of therapy do not adversely affect the deterioration in quality of life. And in particular, when looking at the data related to the different scales, we see that we have a stability from baseline over time, and this is very important considering that patients are treated for many months. So we didn't observe the significant of meaningful differences between treatment arms.
Yeah, I would say like similar to the ER-positive disease, we see new treatment options. For a decade, we had THP, we had the Cleopatra regimen. It worked very well, but now we're realizing we can further improve upon that, and there is room for improvement thanks to TDXT. And now it was announced that also the first line of maintenance tucatinib added to HP is positive, HER2 CLIMB-05, and plus, of course, PATINA, as you presented, palbociclib. So with all of these new options, I guess having options is good, but how do we put them together? Rebecca, do you feel that these subgroup analysis we saw help us to identify patients that may be preferable for TDXT versus PATINA or something else, or not?
Probably not. I think what it tells us is that the data is remarkably consistent. I think many of us worry that those patients that harbor PIK3CA mutations, these are more aggressive patients. We worry they're going to, relapse more quickly. And I think this suggests that it works across all of the relevant subgroups. I think, to be honest with you, we have so many active agents in HER2-positive breast cancer. My hope is that artificial intelligence and all these different ways of, dissecting the data can tell us, these are the patients who benefit from this therapy versus this. We have so many HER2-directed options that I think potentially the future can tell us, okay, maybe you do induction with, TDXD, and then after you've had, I don't know, 6 to 8 cycles, then this is your best maintenance. And maybe some patients you don't need a maintenance. But I think clearly there's a very different biology. And in fact, I think ER positive, HER2 positive, ER negative, HER2 positive, I think the biology is very different. And I think, back to your point of, a lot of people didn't even get endocrine maintenance up until recently. And so that patina data was so important, saying, oh yeah, you actually should do that. So I think it's really shifted that this is like a chronic disease. I mean, people are living well over 5 years with metastatic disease. So the question is, how can we get them to live better, fewer side effects, coming less time to hospital once again? So I think the data are great. I mean, I think it tells us brain mets is something that happens in more than 50% of HER2 positive breast cancer. TDXD is something that has clear activity in the brain.
There is a trial, an interesting one, looking at maintenance treatment after TDXD, the meter. It's a phase 2 trial ongoing with TDXD induction, maintenance, HP, and we're gonna hopefully see the results in the future. But definitely there is so many active agents for this that once was the most aggressive subtype of breast cancer, and now is probably the one that does the best, that we treat the best. And some patients, we think they're cured. We're always scared of using this word in a metastatic setting. But for HER2 positive disease, it feels like in some cases it could be utilized. But now the most aggressive subtype, and the ones actually for which we really need new treatment options, is triple negative. And I know that, Rebecca, you dedicated a lot of your career to improving outcomes for triple negative, and including at this conference, you presented some very important data. So why don't you take us through the data presented at this conference at ESMO in triple negative disease?
Thanks so much, Paolo, and I agree with you. So at this year's ESMO 2025, I think we saw 2 abstracts that are worth sort of having a chat about. So the first one was presented by Javier Cortez, was the ASCENT-03 study. So this was a study in the first-line setting of metastatic triple negative or locally advanced inoperable. Patients that were not candidates for PD-L1 inhibitors were eligible. In terms of the DFI, so patients that relapsed 6 months or greater were eligible into this trial, and this was a stratification factor. Patients who had treated stable CNS metastases that are allowed. And so about 560 patients were randomized to either receive sacituzumab govitecan, given at 10 milligrams per kilogram, day 1 and day 8 out of a 21-day cycle, exactly as we know how to give it, versus chemotherapy of physician's choice. And this could include solvent-based paclitaxel or nab-paclitaxel or gemcitabine in combination with carboplatin. And this was given on day 1 and 8 every 21 days. Now, unique to this trial, eligible patients were offered crossover to second-line therapy where sacituzumab was provided, because as we know, sacituzumab is now available and on the market for later stage disease. The primary endpoint of this trial was PFS by BICR. These are the PFS curves by BICR, and as you can see there was an improvement in terms of progression-free survival. Hazard ratio was about 0.6, and what you can see there is about a 3-month improvement in progression-free survival. Looking at the toxicity, looking at safety, I think no surprises here. This is a compound that we're all quite familiar with using in our clinical practice. We see higher rates of neutropenia, nausea, but most notably GI toxicity, which diarrhea. And you can see in terms of discontinuations, 4% of patients stopped SASI, about 12% of patients stopped their chemotherapy due to toxicity. So looking at the TROPION-Breast02 phase 3 trial, I'll maybe call out some of the differences in this trial, because both of them were first-line patients with triple-negative breast cancer. Both of them allowed patients whom immunotherapy wasn't an option. One big difference between this trial and the ASCENT-03 is that there was no minimum disease-free interval. So patients basically on the end of their neoadjuvant therapy or less than 12 months, so even less than 6 months within their adjuvant therapy were eligible. It was capped at 20% and was one of the stratification factors. Patients were randomized 1-to-1 to Dato-DXd versus investigators' choice of chemotherapy. Solvent-based paclitaxel or nab-paclitaxel, if they had a greater than 12-month DFI or de novo, most patients got nab-paclitaxel. If they had that relapse in the first 6 months, or first 12 months, they got capecitabine, carbo, or erubulin. The majority of physicians chose erubulin. Now here we had 2 primary endpoints of OS and PFS by BICR. Here you can see this is the primary endpoint looking specifically at PFS by BICR, and you see the curves separate very early and then continue to separate just as quite sustained. So here we see a hazard ratio of 0.57, an improvement from 5.6 to almost 11 months with Dato-DXd, has a delta of 5.3 months. And so now looking at the other dual primary endpoint of overall survival, we see an improvement. Those patients that got chemotherapy, median overall survival of 18.7 months. This increased to almost 2 years in patients receiving Dato-DXd. So a delta of 5-month improvement in overall survival, hazard ratio of 0.79, p-value of 0.0291. Looking at safety, similar to what we've seen with other studies with Dato-DXd, we see higher rates of dry eye, stomatitis, and nausea. In those patients receiving chemotherapy, a higher rate of neutropenia, anemia, and leukopenia. In those patients receiving Dato-DXd, 4% of patients discontinued compared to 7% of patients receiving standard of care chemotherapy.
But now there's the hard questions to address, which of course I will ask you one each, and I would love to hear from Valentina, and then I'll ask also another question to Rebecca. But first, let's go through this.
Yes, I think that Rebecca really did a fantastic job in the presentation and also in this quick summary for us. And I think that this data are really impressive because really we are talking about a patient population where before this data, the available options were totally suboptimal. And seeing these results, seeing that we can have, we arrive at 2 years of median OS in this particularly aggressive subtype of breast cancer. I think that, of course, we can speculate about the differences in the two trials because in the SASI trial, there was the crossover, so probably we will not see a significant advantage in OS, but of course, as very nicely discussed, the point is that we already know that SAS in second line or in further line of treatment can improve overall survival. So it would have been unethical not to offer the crossover in that trial, while for the moment we didn't have at the time of the design of the Dato trial, we didn't have this data. So of course, if we look at the OS subgroup analysis, it seems that the benefit seems restricted to those patients who do not have access to ADC in subsequent lines of therapy. But I think this is just a speculation, and probably future AIs will help us in designing algorithm for the sequential treatments.
Biomarkers is always the key word, and you're doing an amazing job with biomarkers for metastatic breast cancer. But another keyword, I think, is also sequencing, because we know that metastatic breast cancer, as you mentioned, Rebecca, before, is becoming a chronic disease. Even triple negative breast cancer is a tough disease. We are often able to give more lines of treatment. And now the question is, if we give a TROP2 ADC in the first line.
Well, it's a great question. So, as beautifully articulated by Valentina, so and I was part of the TROPION-Breast02 study, but in the control arm, 30% of patients actually went on to get a subsequent ADC, and we'll be doing a deeper dive into that. So ironically, a lot of people did actually go on to get subsequent ADC therapy, and there are, like you said, so many other novel therapies, not just ADCs, but bispecifics. I think the important thing is, truthfully, in the triple negative is different in that in the first line setting, 50% of those patients never get on to second line therapy. And for me, that's really quite critical because, if they don't live long enough to get second line therapy, you don't get control of the disease. That's what's really important. Now, I know you're part of a lot of studies looking at sequencing, and can you sequence one after the other? And does it matter? Like, do you just change the payload? Do you need to change the antigen? I don't think we really know that yet. Like, do you need to sequence it and give something in between? But what's remarkable about all of the ADCs, I think, is that they clearly are changing the microenvironment. And that's why this is becoming a disease where you do have long-term benefits because subsequent therapies are more effective. You're changing the microenvironment. And I think the next studies will actually look at how do you sequence them. And I think the other thing that's really unique is that, especially with Dato-DXd, we are seeing activity in the brain. And 10% of patients on this on this trial and about 5% on the Ascento 3, had CNS metastases. And that's the biggest burden for young patients. Patients, develop lung and other metastases, which is devastating in its own right. But CNS disease is really troubling for both the patient and the doctor. So if we can control that, so I think all the next generation of therapies, I think, will help us maximize the benefits there.
I couldn't agree more. And I think I'm gonna try to read through your words and eyes, and I feel that just like me, you're excited about all these advancements. We used to see so many changes in practice in a decade, and now we see them in a conference. We see new drugs, new positive trials across the board for every subtype of breast cancer. And so I do feel energized and motivated to develop even more drugs, to conduct even more trials to improve outcomes and tailor treatments, because now we have options. And so I do feel also hopeful that San Antonio and the next congresses will bring further advancements. But for the moment, I would like to thank you for reviewing the data and commenting on them. Thank you, Valentina. Thank you, Rebecca. And thank you all for joining this program.
Thank you, Paolo.
Thank you, Paolo.